Hello everyone, my name is Kenji Kimura, and today in this video we'll be talking about this paper that I published back in 2021. This work was done at Montefiore Medical Center where I did my residency. It is titled Using Automated Machine Learning to Predict the Mortality of Patients with COVID-19. I know machine learning field is moving very fast, but I want to focus on some points that is always important, regardless of how advanced machine learning gets. So please watch to the end. A quick introduction of myself. My name is Kenji, and I am currently a clinical informatics fellow at Mass General Brigham, Harvard Medical School. If you'd like to get in touch with me, please get in touch with me through LinkedIn, or please leave a comment in YouTube, or you could also reach me through x.com. All right, so I just wanted to give you the link here to the paper. The link is going to be down at the comments as well, and the paper is publicly available. Also, the source code and the data that we used is also publicly available. So if you would like to replicate this study, or if you want to apply it to your own study, the code and the data is also available. All right, so the presentation outline, I want to mainly focus on the critical evaluation of machine learning model performance for this video and maybe for one more video. Uh, but in the following one, I will focus on the black box model, understanding the black box of machine learning models, and the dimensionality reduction. So I don't think we need a lot of introduction about what COVID did to us, but from this study, we were trying to answer if the computer can be trained to predict mortality or severity of COVID-infected patients. If the computer could tell us how severe the patient is, then this will help clinicians to stratify patient care. For example, we could properly allocate resources to people who are more severe, or we could give more attention to people who are uh, more severe and let other people who are less severe perhaps be discharged home. And since we have limited resource of ventilators and bed, we might be able to prioritize who should get it. And this graph shows people who are admitted, which is shown in blue, from uh, March to July of 2020. Blue is people who were admitted, and the orange line is people who passed away. So this is everybody who was admitted at Montefiore Medical Center just between March to July. So it's incredible just looking at this approximately 1/4, 25% of the patient who were admitted died. So let's talk about the method. The data was collected from Montefiore Data Retrieval Software, the clinical looking glass software. And the cohort was collected from the time from March 1st to July 3rd, 2020. The population is all admitted patients who tested positive within 24 hours before or after admission. And the index time is time when PCR came back positive for COVID. So if there's a timeline, patient was admitted, and within 24-hour window, the patient had to have COVID positive. It could be before or it could be after admission, but at some point within that window, the patient had to be positive for COVID to be included into this cohort. The variables that we used in this study were demographic, clinical data, and biomarkers. I'll show all of that in the next couple slides. The data that was collected, the timing that it was collected, is the first value around 36 hours of index time. So within the 36-hour window, whatever appeared first, we will consider as the data for the patient's specific data. For example, if hemoglobin appeared, if hemoglobin was taken for a patient, if that hemoglobin was taken multiple times through this 36-hour window, the closest hemoglobin uh, closest to the index time is what we collected to do the analysis. And then the outcome of interest was mortality from any cause within 30 days after the index time. So I think looking at the chart, it makes it a little bit easier to understand. Um, each row is a patient, and each column is a variable. So that we had about 4,300 patients. So there's about 4,300 rows, and we used about 48 variables. So there is 48 columns. And one of the column is if the patient survived or not. This is a summary of our cohort. The age was approximately 64 years old. The gender distribution, male was about 53%, female about 46%, 47%. Survivors after 30 days was about 74%, 75%. And length of the hospital stay to death was about 8.4 days. So in total, 1,087 patients, about 25% died within 30 days of infection. And these are all the parameters that we used. We collected demographic data, we collected clinical data, we collected chemical and biomarkers, and this all added up to be 48 variables. And then the outcome of interest is dead. We labeled it as 1 and alive as 0. So the last column of the spreadsheet is dead or alive. If it's 1, that means that the patient passed away. Now, choosing the machine learning is always a little bit of a struggle because there's so many different kinds of model out there now. Just looking at this short list, there's decision trees, random forests, gradient boost machine learning models, an XGBoost model, and then the famous deep learning model as well. And then for each model, there's hyperparameters that you have to tweak to optimize the model. So that's a lot of trial and error and a lot of work. So we used something called AutoML, which is a package that runs all of these models and then optimizes the hyperparameter for you. And we used the open source AutoML package by H2O AI. So you could also go to H2O AI and download this package, and then you could download our data and then replicate this study on your own. Or you could just use your H2O AI, this AutoML, for your specific data set that you have for your research. So the overview of the method, we have 4,313 patients, and then we divided that into 80% training set. That's about 3,400 patients. And then 20% of that to test set, 845 patients. And then we take the training set, we run it through the AutoML, and generate the best model possible from all the different kinds of model. And then we'll take all of these models and then test it with the test set, and then run the statistics and try to find the best model possible. So here's the output from H2O AI AutoML. We call this model 48 because uh, it has 48 variables. And the best model was the stocked ensemble model with area under the curve of 92, 0.92. Stocked ensemble is when you take the best of each model and then you kind of bring it as one model. So oftentimes, stacked ensemble is the top model that performs the best. But here you could also see that individual models here as well, like GBM model, XGBoost model, and few more GBM models, uh, and random forest model down here. But overall, they did very good. The single one that did best alone is GBM, and then Stocked Ensemble basically takes all of the best parts of all of these models and then stack it into one model. And then it got area under the curve of 92, which sounds very good, right? But we need to think about if area under the curve is really appropriate in my study, in our study, or in your study as well. Oftentimes, area under the curve is what we use to evaluate machine learning models. But is that really correct? Is something that we need to always think about. And to do that, we need to have some clinical knowledge as well. And I'll get into that more in detail in the next video.